Hi, I'm Kate Hanson from the University of Minnesota. We're presenting sacral neuromodulation testing and parameter details in a single center's patient records, opportunities to improve clinical outcomes, and therapeutic technologies. Sacral neuromodulation is an implantable electrical therapy used as third-line treatment for refractory bladder pathology, including incontinence and retention. A small device is implanted subcutaneously in the patient's back with attached electrodes that are pushed through the medial aspect of the sacral foramina towards the S3 nerve root. This is done in the operating room using fluoroscopy, as seen in the upper right-hand corner here. Those implanted leads are thought to interfere with afferent sensory fibers and modulate the activity of the lower urinary tract, therefore leading to symptom improvement. Beyond the anatomical location determined in surgery, the device itself has many possible settings to deliver the electrical impulses, specifically pulse width in microseconds, stimulation frequency in hertz, and duty cycle, or the repeating on versus off time. Each device is then programmed to get the right balance for a patient, finding sufficient efficacy without undesirable sensations or pain. These parameters have the ability to drive individual therapy, as well as innovations in the technology and our overall understanding of the mechanism by which this works. Recent research, specifically Tilborough's and colleagues, reports that repeated testing over 3 weeks postoperatively improves early success of the therapy as patients transition to permanent from test therapy. Knowing this, our question was whether we have this information at an institutional level. How well are we documenting device threshold testing, efficacy, and therapy recommendations and settings? We conducted a retrospective chart review of 127 clinical and surgical records from 40 sacral neuromodulation patients. We essentially went through the chart for all physician-driven documentation, including operative and clinic notes, and transcribed comments relating to device therapy settings, descriptions, how it was working for the patient, and any mention of quantifiable parameters. Our results can be divided into the two categories of how therapy is titrated. First, visible motor responses, and second, subjective reports of sensation from the patient. In the operating room, when the patient is asleep under general anesthesia, the motor response is most determinative of correct placement, specifically looking for ipsilateral great toe dorsiflexion and bellows response. Documentation of motor responses is incredibly consistent for the initial implant under general anesthesia, seen here as the S1 implant at 100% for qualitative outcomes. This response is also sometimes elicited in the permanent implant, also under general anesthesia, seen here as the S2. After that, it's not something that is often elicited in a clinic setting or retested before explant. In contrast to motor, sensory responses are most consistently seen in the initial surgical testing environment with the percutaneous nerve evaluation. In this case, the patient is awake. This is seen on the left here at 80% for qualitative outcomes. These operations don't include a subcutaneous device, just testing of the leads. And overall, there are challenges in timing and documentation as it's unclear whether the operative notes include testing done by the device representatives in the recovery area. Sensory reports are occasionally mentioned later in the patient's clinical course, particularly if something is raised by the patient, but we don't see documentation of device interrogation or altering of specific quantifiable parameters. For both sensory and motor data, we see a paucity of information on quantifiable parameters. We rarely see mention of which electrodes were tested, or exactly which parameters or programs were being used. Our conclusions from this study are that there is a lot of room to standardize and enhance our clinical surveillance and data gathering related to these devices. We see only 7% of the time are we documenting therapy settings, and even then it's most often nonspecific, mostly stimulation intensity. When we do see mention of efficacy, which is up to 50% of the time, the descriptions are often limited to generalization, such as greatly improved or no improvement, and ballpark estimates. This study has identified a need for documentation of acute device testing, outcomes, and device parameters, as well as a need for therapy parameter documentation, tracking that along with efficacy during a patient's clinical course. We began to talk to other groups of whether other people are sensing the same lack of data and documentation at their institutions, and we're really excited to use these outcomes to design a future prospective short-term therapy test trial. Our ultimate goal is to improve clinical acute testing and determine the feasibility for using that data for prospective device design inputs as we seek to improve this technology for our patients.